Hello. Now, the important thing here is you're at a lecture, you're here in person, but why are you here? Why don't we just do this via Zoom? Why did we come all this way? And really for us, what we want to do is more than what you could plug into AI, more than what you could see online. Anyone can do this. We want to give you a different way of thinking for you, your patients, and the way you run your clinic. So first up, we're going to have Tony going through some complex cases, and I'm going to come back, I'm going to go through one more complex case. Over to you, Tony.
Thank you. I'd just like to say how grateful I am for the opportunity to be back in Vietnam and visiting this wonderful country and beautiful city of Ho Chi Minh with this most generous and friendly people. So thank you. It's a privilege to be here. I have previously presented a case here which was a difficult case because in treatment we had to extract lateral incisors and there was not much bone over the canines, and so it was really trying to control the canines, which can be very difficult while closing spaces. So this is a case where we thought outside conventional orthodontics and used a overlay big talking spring, and these were developed back in the 50s for orthodontics, and it was actually very effective in being able to control the bone levels around those upper canines as we close the spaces. I'd now like to talk about another case that provided some challenges, and it was referred to me by a maxillofacial surgeon. This is a man in his 30s, and he has crowding in the lower arch and an occlusal cant, and he also had a 2-6 which had been marked as basically zero prognosis for the future, and he had a 2-5 which hadn't fully erupted. And there's the 2-5 there. There's his cephalometric analysis. You can see it's got quite a tight incisor relationship. So we thought we'd extract the 2-6, the 3-4 and 4-4 to relieve the lower crowding, and apply orthodontic traction to the 2-5 to bring it down. Explained that these cants are very difficult to correct, and anyone who has tried orthodontically to correct an occlusal cant will appreciate that point. So just a quick time frame that we extracted the 2-6, and then we had some problems as we tried to pull down the 2-5. As it turned out, the adverse effects with the 2-5 that we were experiencing were because the 2-5 was ankylosed. So we warned him about that, so we had to go back and have the 2-5 extracted. We put in some TADs to also try to correct the occlusal cant, and they all failed. So I then went to a bone plate. So there's an OPG showing the 2-5 as we tried to bring it down. And I started by running simply vertical elastics off a very heavy lower arch wire, but rather than the lower arch dropping down, as I thought it might, usually when you get a bit of wide opening after the teeth going up with ankylosis, it usually comes down quickly. The lower arch was extruding, and that was causing complications. The TADs had failed, so we went back and we put in a bone plate. So the important thing here was the monitoring of the progress and seeing the patient on a regular basis, so you didn't go for a long period of time with an adverse effect. If you wait for a long period of time and you get some significant extrusion of that lower arch, we will never correct it again. So things were actually going quite well. The occlusal cant was correcting nicely. I kept running the elastics off the bone plate here, and we just kept correcting it. Then we had to upright the 2-7. We weren't going to try to close that space. To bring a 2-7 through a space that was occupied by the 2-6 and the 2-5 is really too ambitious. There's enough work to do. And so we planned for prosthodontic replacement here, which I was quite happy about. Facial aesthetics are good. Just pulling things down. Keep them going for a minute. Thank you. Then we removed the bone plate and we had to close the space between 3 and 3-5 where the bone plate was sitting. And we were able to complete the case with good alignment of the teeth, a good functional occlusion, a nice space for a prosthodontic replacement in the 2-6-2-5 region, and we were able to level the occlusal cant. It just was the importance of really monitoring and having to do things a little bit differently than planned. Thank you.
So, I have a secret for you guys. I'm from Australia, and what this means is we have drop bears. So watch out for the incoming koalas. There is some advantage to coming to an in-person lecture. Now, let's see if we can get those. Really why we're here is for me to talk about this case. So I had a lovely 10-year-old female come in. Everything looked pretty good with her teeth. You know, not too many problems. Yeah, maybe there's some things going on, maybe there's no laterals there, but overall things looked pretty good. Until you start to look a little bit more deeply, you start to look under the surface. Once you get under the surface, you start to see some more problems. We have got 2 upper impacted canines and 1 lower right impacted canine. Taking a CBCT, we want to have a look at these because it looks a little bit resorbed. But when you have a really close look at this CBCT, and if anyone wants to come in and come up to have a chat to me afterwards, I have a 3D printed model of this. You can come and see exactly how impacted these teeth are. So come up, have a chat, I'll show you the 3D model. But while you're out in the audience, you might as well look at the slides. So, big class 3, very impacted teeth, and they're actually wedged under the CEJ into the pulp chamber of that central incisor. So we went off to go see an endodontist. The endodontist said, look, these teeth are hopeless, just take them out. Mind you, she's already missing 2 upper lateral incisors. The 2 upper central incisors were giving a hopeless prognosis, and the 2 upper canines are impacted, effectively meaning 6 missing front teeth. Anyway, luckily for us, it shows that the research shows that orthodontically induced resorption and resorbed teeth can function as normal. And long-term, their prognosis isn't from the resorption itself, it's from other factors, such as the endodontic status, so we want to try and keep them vital. It's also from the periodontal status. So, we came up with a plan. She's 10, what are we going to do? Well, we want to preserve bone. And this goes for our cleft patients, and this goes for our patients with these severe deformities. These teeth may not last the rest of her life, but we want to preserve bone to give her as many opportunities as possible. The next thing is we want to try and maintain those incisors for as long as possible. I know we've got a hopeless endodontic prognosis, but we might as well give it a go. Best to try and save what you can. And finally, we want to disimpact. I'm an orthodontist. I want to get those teeth out and down. We're already missing 2. Other 2 are bad. Let's try and help those last 2. So we came up with a surgical plan with Mr. Besley, And we use a modified Cockage exposure protocol where we maintain the follicle. And that's really key for maintaining the vitality of those teeth. So we modified it to avoid disturbing those pulps. Remember, those teeth were wedged under the CEJ right into the pulp of the central incisors. We want to keep it so that they are maintained and ideally stay vital. So, the surgical goals were maintain an adequate cuff of gingival tissue. We wanted to preserve the gingival crevice such that the central incisors were preserved. We wanted to retain the dental follicle so that the pulp chamber of those central incisors did not get exposed. And these are things you can take back. We are trying to preserve in a hopeless situation. For your patients, sometimes that is the best option. You need to go, we're not just going to take them out because of this. You come up with clear goals, and those goals might not be ideal, but the goals are something you can agree on, the surgeon can agree on, and the patient can accept. We want to leave the bone undisturbed around those central incisors, and we want to remove the bone away from those upper canines so that we can direct them away from those central incisors. I'm also going to use this CBCT for my orthodontic purposes. I can see where things are, and yeah, I can 3D print it as well to really see where they are, but I can plan my forces. I know those teeth are wedged up and in, so I actually want to intrude and pull them back to start with. I don't want to try and pull the canines down because that would pull them into the central incisors. I'm using the resources I have available to me, including CBCTs, to plan not just the surgery, but the orthodontics. And you really need to see them in 3 dimensions to help plan your orthodontic movements. So, along comes the case and hey presto, we pulled them back a little bit, and now we can start pulling them diagonally. So we get to see that change as time goes on. We are continuing to use the resources available to us, this CBCT, overlaying them to figure out where things are going and how we're manipulating these teeth. So by this point, the endodontist is like, actually, you guys are doing pretty good. There's no significant endodontic problems. You're pulling these teeth back. We kind of left the upper right canine on autopilot. We unimpacted it, and it can just erupt itself. This is part of the Cockage protocol. If you can leave canines alone to do them by themselves, it is much better for your anchorage. The upper left canine needed a little bit more attention, so we're pulling it away from the upper 4, and we swapped over to a Nye-tie spring because an elastomeric chain crossing the occlusion kept breaking. Trimming bits and pieces off, and continue to distalize that upper left canine. By this point, the endodontist was very impressed with us because the teeth were still vital, and we kind of just decided, let's just let everything go. We can just let her develop by herself. We've successfully achieved those primary goals. We have preserved the bone, we've disimpacted the canines, and we've preserved those central incisors. So we fast forward a few more years, and hey presto, we need to do something more. She's got some crossbites, and we want to just get those canines out of crossbite as well. So some expansion to make the arch wider, and a segmental mechanic not touching the central incisors. They are significantly resorbed. We do not want to move them. We do not want to touch them. We know that they are traumatic. So pull that out. Now, the obvious question is, I'm an aligner speaker, I love aligners. Why am I expanding with regular expanders? Well, if you take any kind of aligner system and you want to expand, a couple of teeth, let's just push those out with some bits of plastic, right? There's a center of rotation, we all learned this in university. Push them out and hey presto, they rotate around that center of rotation. Aligners do not in themselves create that moment of force. And this is why you often with aligners end up with those posterior open bites. And there are some effects on the anterior torquing from overexpanding. Expansion with aligners is not ideal. You can try to make it a little bit better. You know, you can put some attachments on and it kind of helps a bit. You create a slight moment of force there. But really, aligners are not a good expanding appliance. Braces do a better job, expanders do a better job again. So don't expand with aligners. They do have their advantages though. So we've got the expansion, we've got a retainer in, she's happy, disimpacted all the canines. Except they just don't look so good. So she's come back and said, hey, can you make my teeth look good? You've been treating me for a number of years now, but my teeth still look ugh. So what we do at this point, we decide, let's actually do some aligners. So slightly class 3, otherwise looks quite good. Very, very mild on the class 3 side. She fits all the key indications for a single lower incisor extraction, and these are well published. So what we're looking at is mild class 3 skeletal. Yep, we've got that, very mild. We're looking at a dissectable facial profile. So you want to be on the mild side. You don't want to be an extreme class 3 and doing a single lower incisor. You just want it to be a little bit. We're looking at Bolton's discrepancy. She's missing upper laterals, and that's another indicator for a class single lower incisor extraction. We're also looking at moderate crowding. Remember we got that lower canine that's blocked all the way up? I'll pause at the end, you can get a photo of them all, don't worry. We're looking at distally tipped lower canine. And finally, we want to look at that kind of space closure for those missing upper laterals. You take photos. These key features are what you can look at, and they are the literature-based and evidence-based indications for single lower incisor extractions, which is a kind of an underutilized extraction pattern. Here, just before we start some further treatment, looks really good. There is no indication of any further resorption on those upper central incisors. Everything's actually looking quite nice, where the upper incisors are not too far off and things are looking quite good. Now, I'm going to skip through a few slides here. Okay, and we're back. Good. So, we took out the platal arch and we decided, let's just look at this again. The root resorption is lower with aligners. So maybe this is a good case for aligners now. Intermittent forces is attributed with lower root resorption rates. Additionally, we're allowing for some careful planned mechanics. We can choose not to move teeth. I get there's no guesses for which one I'm not going to move. I'm not going to move the central incisors. We know they're resorbed. I can do that with aligner therapy. I've already done my disimpaction. I've already done my expansion. And now I can reduce those forces on those teeth. So we'll do an aligner plan. You can see I'm deliberately not moving the central incisors. Aligners allow me to do this. I'm also slowing the movement in the back end to about 0.5 millimeters per aligner. You'll notice that she has lots of aligners made, but for the initial plan, I slow everything down and I don't move the traumatized teeth. Now, the other thing when you're thinking about aligner plans, and this is built into some software, not into other, but you need to have a look at your final finished model in context of the patient's face. In the end, I deal with patients. She's come in because she wants a nice smile. If I make teeth that look good on a computer, that may not translate into a real patient smile. And there's research on this from 2011 showing that the angle of the digital models displayed can dramatically affect the appearance of a smile arc. Same models, same patient, different angle. It's like looking at a model straight on versus a face mask mounted model. You need to line your models to the patient's face when you are checking your digital plans to build that context in, because in the end, the patient cares about their smile, not about what their teeth look like on a computer. And this is something I've got coming up. Oh, there's a free and open source tool if you've all got Macintosh. There is a Windows version, it's called On Top Replica. I use Mac, so I use Layer X. And this is something that I've got in an upcoming version of the APOS journal, and the full methodology is published there. So open source access journal, as soon as they publish it, you'll be able to get a copy of this. But Layer X is very good. Now, everything's going on quite well. We've got aligners, moving some teeth. Fun. Thing is, we get to about aligner 13. COVID lockdowns happen, and she heard from one of her friends that maybe she should do weekly changes. Now, weekly change is a whole other thing. In the literature, it's mostly suggested they're not so good. But the problem is, her teeth at aligner 13 were actually about aligner 9. So her teeth were further behind. A lot of good aligner software gives you this ability to immediately superimpose and assess where the patient actually is. So at this point, I decided, hey, actually just go back to aligner 9, and we're going to go 2 weeks per aligner. So I didn't have to retreat or do anything else, order more aligners. They're built into the software. I can actually replan and go, yep, we're actually here, let's reset from that point, because that's where we lost tracking. Now, one important thing is, you'll notice that I'm using lots and lots of regular attachments. Attachments is my thing. It's what I like talking about. It's what I talked about at the recent AAO, and mostly it's because I've done a bit of research on attachments. The big thing is, optimized attachments don't work. Orthodontists prefer regular attachments, and these don't work. It's not for any particular reason other than those optimized attachments are optimized for a movement in a single direction. As a dentist, as an orthodontist, how many teeth are you moving in a single direction? We move teeth in a number of directions, so you want a Swiss Army knife. Regular attachments do better than optimized attachments in almost all movements. So, away we go. The other thing is, larger attachments do better, and larger attachments with sharper ridges. So this is probably why optimized attachments don't work. But if you're going to put an attachment on, go big or go home. So, fast forward a little bit longer, things are going quite well. Teeth are back on track. By going backwards, I actually let us go faster forwards. I didn't have to get a refinement done. And you can see here there's a few key things. One, the canine's back on track. But two, can you notice my aligners have got a straight ridge? I don't like scalloped aligners. So it's not just because I don't like them. The thing is, there is a lot of research to show a straight extended trim line has significant benefit for force transmission. And it's not just this paper. The thing is, there is so many papers showing that a straight cut is better. It's one of those things, if you're using a scalloped aligner, such as Invisalign, you are leaving stuff on the table. You are not transmitting your orthodontic forces as well as you could. There is overwhelming evidence that if you are doing aligners, you need aligners with a straight cut. Forget about scalloped aligners. The evidence has moved past that. Invisalign is sitting in the past with this. We need to go to a straight cut aligner. They are superior for force transmission. Now, with this, all things going on, looking quite good. Starting to move some teeth around. At this point, I'm actually going to go, yes, let's start moving those centrals. Again, slowing the movement down, letting everything go nice and easy. I don't want to cause any further resorption. And she's quite happy. At this point, she's actually starting to smile. I've still got some things to do. I need to bring the canines down. I need to line up the centrals. But she now has a functional bite where aesthetically it's looking a lot better. Again, moving on, starting to move those teeth. The important thing here is you always need to do a few refinements. I want to keep it as minimal as possible. I see aligners as par 3. If I can do a hole in 1, I'm really happy, very rarely. Hole in 2 is pretty standard in an orthodontic practice. 3, I make par. I don't want to do more than 3. Patients get burnt out. So we just come up with a little bit of finishing, getting some attachments on there, and overall she was quite happy. So we've got some retainer wires on. It's not ideal, the canines are still setting a little bit. The alignment's actually pretty good. Her smile is what's important to her. As an orthodontist, I'm looking at other things, but for her, she is very happy. And going from a situation where she was missing 6 front teeth, effectively, to a situation where she has a normal smile, she's very happy. Importantly, with these mechanics, careful planning, careful thinking, having a staged approach where you have set goals at each time allows us to move those teeth in a safe way, preventing any further root resorption. She's very happy with all her smile, still mildly class 3. But the key things in this case, you need to preserve the bone. You need to try to maximize your dental aesthetics. You want to keep their front teeth looking nice. Use your CBCT not just for any surgical planning, use as an orthodontist to plan the forces. You will then move the teeth based on what you can actually see. It's not good for all the time, because as things move, it moves. But it allows you to at least plan that initial movement. Using progress scans to allow you to go back and forward with your aligner numbers without having to move too far forward and then do a refinement means that you can save the patient time, and you can actually save time as it goes. And there's AI tools that now can do this progressively, including some ones that patients can scan at home. Now, you minimize the movements for those teeth, and you want to make sure you're really slowing it down where those resorbed teeth. big square attachments. If you take anything away from my research and all the stuff I do, you want your attachments to be big and square. Forget about optimized attachments. They just don't work. Straight trim lines puts the force on as well as it possibly can. Scalloped aligners reduce the force, reduce the amount of application of force on those teeth, and there's about 16 research papers now showing that. So, if you want to get in contact with me, you can jump on my Instagram. You can see what I did at the AAO and the EAS because I was over there talking about aligners. But really, the key things for both of these cases, and the tips for success, have your treatment plan and have a backup. So the backup for this girl was, well, we might lose the central incisors. It's better than going straight to that at the beginning. So you have to make sure you tell the patient that backup right from the beginning. If you tell them at the treatment planning stage, you've already planned in your mind, okay, plan A, plan B, plan 1, plan 2. Then it's not an excuse. It's, okay, well, something happened. We have to go to our backup plan. It's not ideal, but we knew that from the beginning. If you tell them halfway through treatment, they're going to get grumpy, like, where did this come on? Who stuffed this up? So tell them the backup plan from the beginning. You then need to carefully monitor it. So for this patient, we were taking regular x-rays, we were regularly feeling and those teeth for mobility, and the patient was regularly seeing an endodontist for vitality testing. We were regularly monitoring for any changes that would mean a change in our plan. If it's all proceeding well, just keep going. You know, you don't have to change. If not, you can change to your backup seamlessly. Now, I'm going to say thank you to everyone for having us here. So these are pictures of Melbourne and Uluru, and this is from Tony when he's flying his aeroplane around Australia.
Yes, thank you everyone for your attention. And again, just to emphasise that I always go into a case with two plans, a backup plan. The first plan may not work, and I can send the patient to the backup plan before treatment. Sometimes the backup plan will involve orthodontic surgery. You really want to do all this beforehand because patients hate surprises. They don't like changing the treatment plan, but they actually hate surprises. And certainly in Australia they can punish you, unfortunately, legally, if something like that happens. So, but it's for the benefit of the patient. This really makes them have confidence in what's going on. I'd just like to again thank you, and I'd like to, before Linton shares the same thought, thank you everyone for the wonderful hospitality. I'm always overwhelmed by the hospitality and generosity of Vietnamese people, and you know, Ho Chi Minh is one of my favourite cities in the world. It's like coming to a second home every time I'm here. So thank you everyone.
Thank you, Dr. Tony Collett and Dr. Linton Nash. I think that we study about many techniques in orthodontics. So we invite Dr. Chánh to get the certificate. Thank you, Dr. Chánh. And now we go to